Thank you for the invitation, Professor Walz, for here to talk to you and discuss the topic of salvage lymphadenectomy in prostate cancer patients. Well, in our experience, I think it's really important to have exact staging beforehand. I don't know. I mean,
that's basically we only can open up this treatment possibility of salvage lymph node dissection or salvage treatment in a relapse setting after imaging and identification where lesions might be. And the only possibility to do this today is PET-CT or PET, and then it depends, of course, what tracer you use. Choline PET is the only possibility that is widely available, and you have now the possibility to work with PSMA tracers. And
yeah, I mean, in our experience, we see now at lower PSA levels positive findings, and then we can discuss, well, if this patient really is the right candidate, maybe for going for an individual concept and removing those nodes as this might be a good option for the patient before considering medical treatment.
Probably the selection of the right patient, we had that yesterday in the meeting under the line, the conclusion was you need to select the right patient at the right time point to do the exam. What are your indications to do the PSMA PET in the relapse setting?
In the after radical prostatectomy, when we had the operation, maybe also radiation therapy for local or suspected local recurrence, but the PSA is still rising or is still very low, then when we might have the chance of a individual concept of maybe salvage radiation therapy to lymph nodes or salvage operation, then this is, I think, a good patient for imaging to decide if he might be the right candidate.
Do you consider already, or do you have ideas of any PSA cutoffs that are helpful, like to say below 0.5 it's still not really working, or is the lowest cutoff not really an issue?
Well, we see between PSA levels of 0.2 and 0.5, we see about 50% of patients with positive lesions. So I think we should really aim for those low PSA levels below 1 at least. When the PSA is a little bit higher, I mean, the possibility that the spread is there is increasing, of course.
Do you have any ideas on PSA velocities or kinetics, like a PSA doubling time, which is informative for choline PET, and maybe it's also informative for PSMA? Do you have any information on that?
Yeah, we looked at our patients, and actually at this low PSA levels, we found that doubling time especially is not really a good parameter because just the PSA levels are so low. Velocity might be a good candidate or a better candidate to identify patients, and then of course the course of the disease of the patient. When did he receive surgery, when radiotherapy, and the time window, I think, is also important.
Do you select any radical prostatectomy parameters to select people to do a PET scan in this situation, like aggressive disease or extended disease initially, or it's really like the time frame between the surgery, the treatment and the relapse, which helps you to select the patient for this exam?
I think for primary imaging, as long as we're thinking there might be a chance for a local concept, local treatment concept, I think we can basically do imaging in all those patients. But for treatment then, people with a lower time interval, a smaller time interval, might not be profit that much, or with higher Gleason grade might also don't profit that much.
There are other markers that are dedicated or designed to improve the detection rate in this situation, and this FACBC. Do you have any experience with this? Well,
we personally not. I know there are several groups working with this tracer, and it's also, I think, in my eyes, a very promising tracer. And up to now, I think there's no head-to-head comparison to those two tracers. I think what one can say that probably tracers like FDG or choline will diminish from prostate cancer staging in the future, but about these two tracers, I think you cannot say right now which will be the most promising candidate.
And do you have any ideas why PSMA is working so much better than choline in the initial staging setting?
Well, I think we're talking here about functional imaging, but in reality, PSMA is a protein located on the prostate cancer cell. It's not a metabolic process which has been visualized. So inflammation or just other metabolic changes don't interfere in this kind of imaging. So I think that's why also the specificity that we see in the primary setting is so high.
There is still, you showed that yesterday, some what I would call cross fixation on other organs. I think it was liver, was in small intestine, and something else.
Well, the urinary tract, the salivary glands, they show PSMA expression actually. Also, there has been described some expression in the lung tissue, in the brain, and then of course it is metabolized via liver, spleen, and then excreted through the urine. But the important sites of primary metastasis, lymph nodes or bone, they basically don't take up PSMA.
And how is your experience with bone imaging with PSMA if you really look only for bone metastases?
I also think here PSMA PET has the opportunity to maybe even replace bone scan because it also shows bone lesions very nicely, and it's not unspecific as the technetium tracer for bone scan.
And just a theory, you could imagine that a very high-grade prostate cancer loses this antigen as some prostate cancers lose the possibility to produce PSA. Are you aware of cases where you might have a very high-grade cancer that did not fix, and you had like the classical imaging studies that showed metastases? Are you aware of this in your experience?
I mean, there are primary prostate cancer patients that don't have PSMA expression, about 5 to 10% at max. And then also PSMA expression will be lost actually in castration-resistant prostate cancer later on at a later disease stage. And here, FDG as tracer has been discussed. So it's not like a one-size-fits-all examination, and I think in the future we really need to see what kind of disease state we are in, what kind of tracer do we use.